And this is when we turn our attention to the second portion of our program, which is our panel discussion. Her first panel is titled Breast Cancer. It will be moderated by Dr. Aisha Lofters, who you've just met. And Dr. Aisha Lofters is the medical director for the Peter Gilgan Center for Women's Cancers at Women's College Hospital. She's also a family physician at the Women's College Hospital and Family Practice Health Center. And she's also the associate professor and clinician scientist at the Department of Family and Community Medicine of the University of Toronto. She has a chair in applied public health, advancing health equity in cancer screening and prevention with the Canadian Institute of Health Research. Our panelists are Dr. April Swoboda, medical oncologist, Francine Holness, our breast cancer survivor, Dr. Nazik, Hammad, our medical oncologist, and our Dianne, Bissessar, our breast cancer survivor, and Nancy Akor, our nurse practitioner. Please join me in welcoming our first panel discussion on breast cancer.
When I look in the mirror, I see someone who has faced more than her fears. I'm a warrior. I am a teacher, a friend, and also a cancer survivor. Triple negative breast cancer is a more aggressive form of breast cancer that doesn't feed off of hormones. There were things that I just didn't know what to expect, and it affected me differently as a Black woman. I'm grateful because I had a few Black nurses who were able to help me identify some of the symptoms that I would be seeing, particularly in my skin. My skin tone changed a lot. The hair loss was probably the biggest shock. You know, you think about losing the hair on your scalp. You don't think about losing every hair on your body. Your eyebrows are gone, your eyelashes are gone. I mean, we have a history of hair and politics with hair and what is beautiful, what should you look like. I love myself more at this point because I've gotten through all of that and I see what's real. I feel more confident in myself. I do think there is stigma in the Black community. That might be that old school mentality. Don't tell people your business. It's a bizarre sort of predicament to be in where you are the one who's sick, but then you are feeling guilty for being sick. I'm often having to remind myself that it's okay to take the help and, you know, I do deserve it. Now I make my choices. I'm living life on my terms. So I just surround myself with the most important people in my life, my loved ones, my family, my friends. They were my army, literally my army. For me, beauty is, it's more about a feeling now. I feel beautiful when I feel good on the inside. Truly, that's more important to me than anything now. I appreciate that my body got me through. There's not a lot I'm afraid of anymore.
As a Black woman, I have always felt like the weight of the world was on my back. Raising kids and juggling family, trying to prove myself at work, or watching my tone and behavior so that I wasn't labeled difficult or arrogant. Even how I wear my hair is scrutinized. And when it came to my health and taking care of myself, it was no different. I needed to fight that much harder to be taken seriously about my well-being. When I found my lump at the age of 43, I was working 2 jobs and single parenting 2 young children at home during the pandemic. At first I thought it was just menstrual changes. I didn't have time to see a doctor, but when it didn't go away, I finally went to see my doctor. Due to the pandemic, my mammogram and ultrasound were delayed for months, but I knew when I was there that something was wrong by the number of pictures and time spent. A follow-up biopsy confirmed my worst fears. it was cancer. We'd do treatment and it would be gone, so I thought. Little did I know it was just the beginning. After further testing and scans, I got the devastating news that it had spread into my lymph nodes and bones. I had stage 4 cancer and was given 2 to 7 years to live. I had to plan my funeral, I thought. I questioned every decision I'd made my entire life. Like whom, what, and when did I do something to deserve this? How could I have this when I have 4 kids that need me? Being diagnosed during COVID meant every scan, test, and appointment, all done alone. White walls, white doctors, and white patients surrounded me. It wasn't until I moved back to a larger city that I started to see other ethnicities in the waiting room. I wished there had been another Black woman I could talk to, someone whose images I could look at to see what my scars might look like after my double mastectomy. I wished for a doctor who understood the unique challenges of being a Black woman with cancer. Instead, I had one whose only suggestions for a Black mother was to remove my tubes and ovaries. I wished my pain had been taken seriously and investigated further, especially when even the nurses had shown concern. Instead, I had a doctor who compared my pain to his. I finally had to make a choice. I could either sit silently and let cancer kill me or fight to live. I decided to stand up for myself. I was done being dismissed. I needed to be heard, so I took it upon myself to reach out to other doctors, and finally had success when I met my palliative care doctor. She listened and helped me find my way forward. I fought to return to my original medical team so that I could be surrounded by doctors who believed in my quality of life. I have learned throughout this journey that during difficult times, you are allowed to lay down the weights and ask for help. I've learned from this diagnosis that I can't allow my pride to get in the way of my well-being. I've learned to change my perspective and re-examine what it means to live. I've lost friends and gained new ones. I dug deep into my spirituality and developed a strong relationship and faith in God. Even if all odds were against me, I now believed I can live. The uncertainty of what the future might hold can be consuming at times, but I have no doubt that I will get through this, and so will you.
Thank you so much. Those were 2 amazing and powerful stories and really set the tone, I think, for the conversation that we now want to have. So good evening, everyone, and welcome to our panel on breast cancer. We will also be diving into an under-discussed area, which is metastatic breast cancer. So breast cancer is the most common cancer among Canadian women, and we know that Black women face unique challenges, including having to navigate a healthcare system that has not been designed for us. We know from research that African American women are 40% more likely to die from breast cancer compared to their white counterparts, and we know that we are way behind in studying racial disparities here in Canada. So tonight, our panel will discuss these disparities, share personal experiences, and explore solutions for improving healthcare equity. And we will leave time at the end for questions from the audience. So thank you all for being here for this crucial conversation. So our first question, jumping right into it, is going to be for Nancy. Nancy works as a nurse practitioner. So Nancy, our question for you is, what are some common risk factors for breast cancer, and what steps should one take if you notice a lump or an abnormality in your breast?
Sorry, just having some video problems. If you can start my video, that would be great. So age is a risk factor. Women less than 25 rarely get diagnosed with cancer. Being a woman assigned female at birth increases your risk 100 times more than being a male assigned at birth. Alcohol consumption increases your risk. Being overweight, depending on your menopausal status, according to literature by Dr. Chlebowski, also increases your risk. Smoking, as we've heard with Dr. McInnes as well, increases your risk in breast cancer as well. That Black woman label of having dense breast increases your risk. Birth control provides a temporary increase that disappears within 1 to 2 years of discontinuing birth control pills. And race, although the age-adjusted incidence of breast cancer for white women is higher, Black women more often are presented with advanced disease, which is 46% versus 36%, and had a 41% higher breast cancer specific mortality rate. Just like in that video, we heard about that triple negative breast cancer. Women less than 40 years old and having triple negative breast cancers are more common among African Americans than white Americans. If you do notice a lump, please see your primary care provider. Advocate for yourself, right? Breasts are generally lumpy, but we have milk ducts in preparation for breast milk or production for to nourish an infant. That's why it's good to know your breasts. Feel the lumps. Are they on both breasts? Are they tender? Are they movable? Anything you notice that's different, and if you're in doubt, you can always book an appointment with your provider. I would always raise a flag to a lump with a change of skin, like that orange dimpling, orange peel dimpling kind of skin, or the tone, discharge from the nipples, inverted nipples that weren't inverted before, especially.
Thank you very much. So those, I think, are some concrete risk factors and signs and symptoms that people can think about. April, I'm going to turn to you to ask specifically about the role that genetics can play in breast cancer.
Sure. So the majority of breast cancers are what we would describe as sporadic, meaning they just happen. As Nancy said, the biggest risk factors for developing breast cancer are being assigned female at birth and having breast tissue. But about 5 to 10% of breast cancers are what we refer to as hereditary breast cancers, meaning they're related to your genes that you were born with. So you can inherit from your parents a mutation, what we refer to as a pathogenic mutation in a gene that can significantly increase your risk of developing breast cancer. So some of the more common genes that you may have heard of are the BRCA1 or BRCA2 mutations, also referred to as BRCA1 or BRCA2. And I just want to put a plug in for knowing your family history. One of the comments in the first video was that sometimes, Black folks don't want to talk about their business, but it's important to know your family history because that's how we make the determination of who's eligible for genetic counseling and genetic testing. So when I see a patient in clinic, based on their clinical features, their age of diagnosis, the type of breast cancer that they have, and primarily their family history, I'll place a referral to our genetic counselors. So it's important to know your history of your parents, your grandparents, your aunts, your uncles, your cousins, your siblings, because all of those things go into our understanding of whether your breast cancer was a sporadic breast cancer or hereditary breast cancer.
Thank you. Now, one topic that's been in the news quite a bit recently is around breast cancer screening and when someone should start. So Nancy, can you talk a little bit about when should someone start screening for breast cancer and how often should they be having screening done?
Sure. This is exciting for me because I remember having a 34-year-old Black woman come in and breast lump, and it turned out to be stage 4. So starting fall of 2024, Ontario expanded the publicly funded mammogram program through the OBSP, Ontario Breast Screening Program, from 50 to 40. You don't have to wait till fall, by the way, to complete that screening. But new guidelines also published in JAMA recommend that screening start at age 40 and continue every 2 years until age 74 to better serve these younger women that are having that. There's like a 2% increase in breast cancer diagnosis per year among women in that age bracket. So if you're 40 to 74 and you can go ahead and have a mammogram done every 2 years. Even if you're older or younger, talk to your healthcare provider about whether having a mammogram is right for you. Although there are some critics who think a conversation is better than screening, ultimately it's your decision, and I want you guys to be proactive in your health.
Thank you. So obviously one way that breast cancer can be diagnosed is through screening, but April, can you talk to us a little bit just about the process of breast cancer diagnosis?
Absolutely. So exactly, the two ways that breast cancer can typically be diagnosed are either screening detected or self-detected. And so with a screen-detected breast cancer, that means that you're not having any breast symptoms. You just go for a routine mammogram, and then an abnormality is picked up. In contrast, with self-detected breast cancer, a woman feels an abnormality in her breast, in her lymph nodes underneath her arm, and then presents for mammographic workup. And so once you've presented and you've been found to have an abnormality, whether you detected it or the screening mammogram detected it, then the paths kind of converge and the workup proceeds from there. So you'll typically have a more in-depth mammogram, oftentimes referred to as a diagnostic mammogram or tomosynthesis, that looks at the breast from additional views, as well as an ultrasound to kind of better characterize the tumor. That will oftentimes lead to what we refer to as an ultrasound-guided breast biopsy. That's the most common way. There are different ways that we can biopsy the breast, and then a diagnosis of breast cancer is made. Typically, after the breast cancer diagnosis is made, then patients oftentimes want to know what is their stage. And so there are many different factors that go into our determination of a patient's stage. They include a few things, including the receptor status of the breast cancer, which I'll discuss more in detail later, the grade of the breast cancer, which refers to how organized or disorganized the cells look under the microscope, and then the size of the tumor on imaging or on physical exam, the involvement of the lymph nodes, so what we refer to as the regional lymph nodes, the lymph nodes underneath the arm, and then whether the cancer has spread beyond the breast and regional lymph nodes to other parts of the body, such as the lung, the liver, the brain, the bone, what we refer to as metastasis. And the reason the stage is important is because stage correlates with what we refer to as prognosis. And prognosis is how do people do long-term based on their diagnosis? How long do they live? How long can they be free from recurrence of their breast cancer? So that's why it's important to understand the stage of your breast cancer.
Thank you. And you used a word there, metastasis. I'm going to turn to you, Nazik, just to talk to us a little bit about what does it mean to have metastatic breast cancer? What does that mean? Oh, you're on mute.
It means that the breast cancer the cancer has spread away from the breast itself and the lymph nodes that are probably in the same, or what April called the regional lymph node, on the same side, under the armpit, in the axilla, or just above the neck, in the supraclavicular area. And so some people may be diagnosed from the get-go with metastatic breast cancer. So when they first come to know that they have breast cancer, we find out that they have metastatic disease, either because of their symptoms or because of the staging, X-rays and CT scan that was done, and that we call de novo metastatic breast cancer. In general, this is about 10% in the general population. However, Black women tend to be diagnosed more with de novo metastatic breast cancer, which is 58% higher rate than white women. And the rest of metastatic breast cancer happen, the woman will have an early breast cancer, and then we try to prevent it by sometimes doing radiation or chemo or maybe hormones, and then or maybe no treatment, but then it comes back, and that will, as stage 4, and this again, what we call recurrence. And this could be higher for Black women, 39% higher risk of breast cancer recurrence. I have to say that, which April will talk about more later, that metastatic breast cancer is a disease of several types of disease, which we call them subtypes. Most patients can be treated. It's not one disease, and people are different. Treatment has to be individualized and based on the cancer itself and the wishes and the preference of the woman who has it. And of course, our goal when we treat breast cancer is for patients to live better and to live longer. And it's very important at the level of the population because breast cancer is very common, in Canada and globally. So therefore, the best treatment or optimal treatment that will improve quality of life is very important and valuable for individuals, families, and for societies.
Thank you. So you touched upon the different, that there are different subtypes. So I'm going to go back to you, April, and can you tell us a little bit about the different types of breast cancer and what that might mean for treatment and prognosis?
Absolutely. So exactly, we kind of talk about breast cancer as if it's one disease, but there are different types of breast cancer that act biologically different and that we treat with different approaches. So every breast cancer, we test for 3 receptors: estrogen receptor, or ER, progesterone receptor, or PR, and then a receptor referred to as HER2. That's actually an abbreviation for human epidermal growth factor receptor 2. So the majority of breast cancers, about 70%, are what we refer to as ER and or PR positive. Because they are referring to estrogen and progesterone, we refer to these as hormone receptor positive breast cancer. So that's the majority of breast cancer in the general population. 70%. About 15% of breast cancers are triple negative, meaning they are negative for all 3 of those receptors. And like has been said before, it's 15% in the general population, but if you look at an African American population, a Black population, the rates of triple negative breast cancer are higher. And then lastly, about 15% of breast cancers are HER2 positive, and those can either be hormone receptor positive or hormone receptor negative. So let's just set that aside. There are different subtypes of breast cancer. The 3 main modalities that we use to treat breast cancer involve surgery, radiation or radiotherapy, and then systemic therapy, which is what myself and Dr. Hammad do as medical oncologists. So most breast cancer patients will have their 3 doctors, patients with early stage breast cancer. They'll have their radiation oncologist, their surgical oncologist, and their medical oncologist. Depending on the type of breast cancer that you have, we sequence our treatments in different orders. So typically, I'll kind of go through a very broad overview. For a woman who's diagnosed with the hormone receptor positive breast cancer that's postmenopausal, typically we will start with surgery first. We'll get the specimen and we'll be able to see the extent of disease in the breast, the lymph nodes. We'll get the stage, and then we'll decide what treatments we're going to offer afterwards. For hormone positive breast cancer, a mainstay of treatment is what we refer to as endocrine therapy that blocks the hormones. And then some of those patients may benefit from chemotherapy, and there are certain tests, something you might have heard of as the Oncotype DX. There are certain tests that we can send to determine whether there'll be benefit for the addition of chemotherapy to endocrine therapy to block the hormones. So that's the typical trajectory for hormone positive breast cancer patients. If they require chemotherapy, they'll have surgery first, chemotherapy, followed by radiation therapy, and then lastly, their endocrine therapy, which is the pill that they take by mouth for anywhere from 5 to 10 years to reduce their risk of breast cancer recurrence. For HER2 positive and triple negative breast cancers, those generally always require chemotherapy. Depending on the size, there's some nuance, but those generally require chemotherapy. And we'll typically deliver that chemotherapy prior to surgery. So that's different from hormone positive breast cancers. And it's important because you might have had a friend or know someone who had their breast cancer treated one way, and you hear that your breast cancer is being treated another way, and that might confuse you or make you doubt the treatment that you're receiving. And it's important for you to always feel empowered to ask your doctor questions and to make sure that you understand what's going on. But depending on the type of breast cancer, like I said, we treat in different ways. So for triple negative or HER2 positive breast cancer, we'll typically do chemotherapy first, which we refer to as neoadjuvant chemotherapy. Then patients will undergo their surgery. And then depending on what it shows at the time of surgery, we'll decide what treatments we're going to do afterwards, whether it's more chemotherapy. Oftentimes, if you've had a lumpectomy, you'll have radiation therapy, and then we'll go from there. That's kind of a very broad overview of the subtypes and how we treat breast cancer.
Excellent. Thank you. I'm going to go back to you, Nazik, Dr. Hammad. What is the long-term outlook for someone with metastatic breast cancer, and what factors might influence that outlook?
And so as I said before, most of the time it's treatable, and the factors actually is what determine the outlook. So the factors can be related to the cancer itself, which is what April has talked about, but also can be related to the person who has the cancer. So starting with the cancer itself, what we call like the burden of the cancer, how much it's there. Is it in the bone? Did it go to the bone on the chest wall only, or did it go to the liver, the lung, or the bone marrow, or the brain, even if it went to the liver, how much is it and how it is affecting the liver function. And other factors related to the cancer itself is the receptors, as April talked about. The other related factor is the person who has the cancer, their age, their overall health and other health problems, their organ function, is the liver working well, their kidney working well, and also their ability to handle the side effects of the cancer drugs. Other factors are also related to the environment, the social support, their ability to access care, and also their trust in care, especially for us in the Black community. And also these factors can in turn be influenced by other factors such as chronic life stresses, such as racism, poverty, and unemployment. In general, within the last 5 years, we know that some of the top types like HER2 positive breast cancer, now the survival is much better. It has reached 5 years, and so some people can live longer than 5 years, but some people may not make it. Again, the hormone receptor positive also, some of them can actually live up to 10 years and beyond, and some people may not make it to that. So it's really kind of a spectrum of disease. Even now, we see there's some talk about people who have very little spread, they may be cured. So that's really a very small percentage. But in general, the most important thing is for people to live better with a good quality of life, and the way we treat breast cancer must be individualized. So actually, really rarely any person will be treated the same way, but it's both based on the cancer itself and also on the patients, their circumstances, their health, their preferences, and the way they handle the treatment.
Thank you. And a follow-up question for you, and you touched a little bit, you mentioned side effects, and we know that there can be side effects of these treatment. If we think about radiation, chemotherapy, systemic therapy, some of those can affect the skin and look differently on Black skin, for example. So for women who are going through treatment, Black women and women of color, what are some of the signs and side effects that they should be looking out for?
Yeah. So I guess regarding radiation, and I have to here, I like to mention that for me, women with metastatic breast cancer, not everyone will get the same, maybe someone never get surgery, some will never get radiation, and most will probably get chemo or hormone therapy. But in general, regarding radiation, we know that a lot of studies have been done in especially in the US, but there are some studies that will be starting here in Canada. We know that women, Black women, tend to have a lot of skin changes related to dryness, the soreness, irritation, and sometimes the darkening of the skin, and also some areas of redness when we compare them with white patients. And the problem is this. Most of the research show that these are under-recognized or missed by physicians. So a recent article that was published in JAMA showed that those who are, the women who are likely not to, people would not know that they have these or under-recognition is actually Black race, younger age, and sometimes if you are treated by a male physician. So what we need improvement in communication and education and empowerment of patients, and that's what a lot of us are engaged with. Regarding chemotherapy, it really can affect Black skin. So one of the most common thing is darkening of the nails and darkening of the skin itself. So a lot of the time we see Black spots in the hand, in the feet, and the whole skin may get darker. And sometimes you can see it actually in the mouth and in the tongue and other parts of the skin. And most of the time people say, oh, this is one drug, which is 5-FU or capecitabine. But I have seen it with most of the other chemotherapy that we use. And a lot of the time people do not know what it is. And of course, most of the time these are temporary and they're not painful, but they can be sometimes permanent. So people can really get upset and stressed out because of that. Other things like some of the chemotherapy can affect the hand and foot. And if you look at the textbook, they will say, okay, the hand and foot syndrome is redness, but sometimes in people could be soreness, and also it can also involve the other areas outside the soles and the hands. So you need to kind of know about that. And lastly, a lot of the time, people think that Black people are not affected by the sun. But actually, a lot of the chemotherapy and drugs that other than chemotherapy can cause what we call photosensitivity. You can become very sensitive to the sun, so you can cause itching, and then you can get sunburn. And your skin may not become very red, but you can feel the soreness, and then you can get peeling and sensitivities of skin. So I always tell my Black patients that, you know what, the sun will affect you more if you are on this drug or on this chemotherapy, and you need to be careful, and you need to have similar, do similar things that that people will advise white patients, but do not think to advise Black patients.
Thank you. Very helpful. And I think we've learned a lot on the clinical side. So now I think we can learn a lot on the personal side. So I'm going to turn to both Francine and Dianne and ask the same question of you both, which really is, what did you learn through your personal experiences with metastatic breast cancer, and how did you advocate for yourself as you went through the healthcare system? Maybe we can start with Francine.
Hi. For myself, I learned to advocate for myself. Like I had to, when you are, I'm sorry, I know she mentioned earlier that, you know, your oncologist, you may be hit with a no in regards to, as she was stating, all treatments are different. One doctor may tell you, no, you cannot proceed with chemo, or you can't proceed with radiation. There's always another doctor. Like, don't be afraid to ask a second opinion. Don't be afraid to seek out answers from another doctor if you need to. I really had to learn to do that. I wasn't just relying solely on my oncologist, because I was hit with a lot of no's. Even recently, I went back to get my double mastectomy, and I was told, no, I didn't qualify because of my prognosis. They stated it wouldn't provide me with any additional longevity to my life. So I had to go back to another doctor who believed in providing me with a better quality of life. So continue where you hear a no. Don't be afraid to say, question that, and seek additional support somewhere else.
Thank you for that important point. And Dianne, did you want to comment? Oh, you're on mute.
Hi, sorry about that.
No problem.
So when I was first diagnosed, I found the wait really long to get a mammogram and an ultrasound. And I used my resources. I found someone who worked in a different hospital, and I was able to do it instead of 3 weeks in 1 week. And when I sat down with the surgeon, he told me the biopsy would take almost a month. And I said, well, then could you please transfer my care to Sunnybrook? And he turned around and he was able to do the biopsy in a couple of days. And that was the first time. The second time I was diagnosed, it was during COVID. And, you know, I gave the doctors a bit of grace because of everything that was going on. However, when I went to see my oncologist, he said, no, you know, I had a concern. I had a little lump. And he said, you know, I don't feel it. It's nothing. And when the results came back, I was with the surgeon, and the surgeon was discussing the next steps of getting a double mastectomy at that time. I had only gotten a lumpectomy in the beginning. And when it comes to that point, whether getting, you know, a lumpectomy, a single mastectomy, or a double mastectomy, I believe there needs to be more guidance that is provided, because it's always up to you. And because it's always up to you, you know, they tell you, you know, if a doctor received news of breast cancer, they would get a double mastectomy. but it's a scary thing. Like you're faced with getting treatment, you're faced with your mortality, and you're faced with all these decisions that are basically yours. And it's really, really important to look and get help and, and get guidance and really good guidance. But for me, what had happened is when I was sitting with that surgeon and we were planning, and it took time to, to get a reconstruction specialist in and all different things. My oncologist didn't call me back. He didn't call me to say, hey, I got the results. I'm sorry. And I waited almost 6 weeks. And I was in discussion with the surgeon and one of the nurses, and the surgeon was away. So one of the nurses said there's a new oncologist at the clinic. And so I asked to be transferred. And the office gave me such a hard time and told me I had to speak to the doctor. And of course, I felt a way to speak to a doctor to let him know that his care wasn't what I expected, and I expected more. And I had to tell him, I had to say, there was no support. There was no, next steps after surgery. And he said, I left it with the surgeon. And then I asked to be transferred. And the moment I got transferred to the new oncologist, it was like the skies cleared. He said, I'm going to be your quarterback. I am going to ensure that you get in for surgery right away. And he expedited everything for me. So, there's a lot of control that you can have. And even in metastatic breast cancer, don't feel it's very, very heavy, and it's not really the news you want, and you think about your mortality, but there's so much you can do. There's so many new treatments, there's clinical trials, and there's hope. And especially, spirituality, your faith, it guides you through. But definitely know that you have control, that even if it's the worst news, that you can still have a say in how you are treated, and still gather the information so that your treatment is what you want it to be. It's so important. Anyways, thank you.
Thank you for those very powerful words. And I'm now going to, before we get to the audience questions, I have a kind of a broad question for all of you, which is, what do you want to share? Like, what's a burning point you want to share with our audience, or what would you want them to take away from this evening? And that's for everyone.
All right, I can go. Just like Dianne and Francine said, you really need to advocate for yourself. I had a situation a few months ago where I felt a lump under my axilla, and I went to my doctor, male doctor, I'm just saying, and he dismissed me. Oh, you're 44, and breast cancer doesn't show up like that. I said, okay, well, I am Black, and I really rather just check it out. My daughter ended up having a dream where I told her that I had breast cancer. So I was just like, no, we need to have something done. So he wanted to give me antibiotics. I said, okay, I'll take your antibiotics, but I need a requisition for a mammogram. And, I advocated for myself. He ended up giving me the requisition. And then I ended up having to do an ultrasound. And all these things are very scary. But just to think, this is what happens. We get dismissed, and you really need to advocate for yourself. So if your doctor or your nurse practitioner doesn't want to give you one, self-refer yourself. You are the boss of your health, and just empower yourself and go out there and advocate for yourself. Thank you.
I just wanted to add, because as we mentioned earlier, I think in the beginning, there is a stigma with the Black Caribbean, our cult with Black Caribbean culture is to keep everything a secret. And I know it's easy to carry the load by yourself, but to be quite honest, if I didn't speak up, I would not be here. I would not be able to connect with other Black women. Because when I walked in with my diagnosis, I had a clean slate. I didn't know anything. I knew nothing about cancer. I wasn't advocating didn't know what Breast Cancer Awareness Month was. I knew nothing about it. It's because I opened up my voice and decided to share. Then all of a sudden, all these family members, other people decided to share their stories. And that's how I gathered that information to learn to advocate myself. I had to learn that by sharing my own story because it allowed others to share theirs with me. And by sharing, you allow others to come in and support you. And you really recognize at that point who is really there to support you and who's best there for your well-being. Then when you kind of keep it and try to carry it by yourself, the weight of that on your own. So don't be afraid to share that. And in doing so, that's how you can seek out your family history, finding about, that's how I found out so much of my family members and from other areas and other countries had struggled with breast cancer, because before that, I knew nothing about it. So I owe the fact that I opened up that I'm actually here today, and I'm getting to be here and share that with so many of you today. And I hope that you're able to go back and then share that as well with your network as well, because you don't know who you're impacting.
So I think for me, the diagnosis is really overwhelming, and you quickly want to get treatment and care. However, I think that your first, the most important thing is to really fight that breast cancer, really do the best by yourself, and, be in good health, and know the medications you're taking, and make the right decisions in regard to radiation, in regards to surgery, in regards to treatment. And I say it's because in the beginning I did a lumpectomy, and then I went back and I did a mastectomy. And in retrospect, I didn't realize how difficult it would be to get a second diagnosis. So, and I thought I went all out in the beginning, but yeah, just really, do your best by yourself to get the best treatment, and to really, really know the treatment you're getting, and to make the best decisions by getting resources. Sometimes your doctors don't have everything, all the resources, or even the time. And so, going on groups like the Olive Branch of Hope, meeting women, in the same situation, that can help guide you, because they've walked that road before, which is, I think, very important.
I just wanted to say a couple things. I'll be brief, but first thing I wanted to do is make a plug for palliative care. Speaking of things that we, that are stigmatized and people have a lot of fear about, palliative care, I think as an oncologist, we work hand in hand together to take care of patients, primarily with metastatic disease, but also with early stage disease that have serious symptoms. And the role of palliative care is to provide support from an emotional standpoint, spiritual standpoint, symptom management standpoint. And I think that there's a lot of misunderstanding that patients think that when we refer them for palliative care that we're giving up on them, or it means that they're dying imminently. And that's not the case. It's really important to, I always tell my patients, my goal when you have metastatic breast cancer is for you to live as well as possible for as long as possible, in that order. And I can work on the long with my chemo drugs, but the palliative team helps me work on the well. And so it's important for us to work together. And please don't be afraid to ask questions and to seek that care out. And then kind of on the other end of the spectrum, clinical trials, I know it has come up before in this conversation. I just wanted to put a plug out for clinical trials, an informed plug, because obviously as Black folks sitting here, I'm an American, there's a lot of history of experimentation on Black people, whether directly or indirectly by denial of treatment, like the Tuskegee experiment. And these memories are in our collective memory. that being said, I am a physician and I've written clinical trials and I participate in clinical trials, and it's one of our best ways to offer new, cutting edge treatments to people. And it's really, really important to get Black women to participate in these trials. I want my people to have access to these trials, to have access to these drugs. If you have questions, ask. There's a lot of training. We spend hours doing training about good clinical practice. I think that these trials are safe, and I think that they're well designed in order to answer important clinical questions. But please don't be afraid. And if you're afraid, ask. I know that there's going to be a lot of resources provided. I'm always happy to be a resource to anybody. I'm sure Dr. Hammad is as well. Please, we want to be here for people so that way they can feel empowered to get the best care.
Great, thank you.
I'll just say one sentence is that with adequate resources and shifting attitude, it's possible, to treat most patients, alleviate the suffering of all, maybe cure a few patients, and also to forget or abandon no one. We need to also do research on Black women experience so that we can inform policy and educate the workforce as well.
Excellent. Thank you all for those comments. And now we're going to turn and take some time to look at some of the questions that were in the chat. So first, for our clinicians, are women with large breasts at higher risk of breast cancer?
So Nazik, I'll just
go ahead. Okay.
Take that one. I don't think by definition having large breasts puts you at higher risk of having breast cancer. You do have more breast tissue, which means it's harder to feel if you're doing a breast self-exam. Like if I'm examining my patients with large breasts, I tell them, I don't want to feel something, because by the time I can feel something, that means it's big. So I think what I would say is that for women with large breasts, it's especially important for you to stay on top of your screening mammograms and your screening imaging, because it's, we don't want to feel something. We want to be able to catch it earlier while it's smaller.
Thank you. And another question for the clinicians, just about the risk when it comes to birth control. Is the increased risk referring to birth control pills only, or other forms of hormonal birth control also potential risk factors for breast cancer?
So I actually, when Nancy, you said that, I was thinking there was a large study published in the New England Journal probably about a decade ago looking at the risk of oral contraceptive pills, so birth control pills, on breast cancer. And it didn't show that there was significant increased risk. The only population that there was a concern was possibly patients with BRCA mutations, those BRCA1, BRCA2 mutations that I was talking about. But in general, we consider oral contraceptives to be very safe and I don't tell patients that those increase the risk of developing breast cancer. That's in contrast with things like hormone replacement therapy, which are also hormones, but given for a different purpose. And so, there's a moratorium on hormone replacement therapy in general, because we saw that it significantly increased the risk of women developing breast cancer. But in general, the oral contraceptives that we would use for breast cancer, for contraception, don't generally increase the risk of breast cancer for the general population. So that would be whether it's an IUD, so like a levonorgestrel, a Mirena IUD, or oral pills, the implants in the arms. Those are all, we consider them kind of similarly.
Great, thank you. And then Dr. Hammad, if someone has a personal history of breast cancer, how do we then consider screening for their adult children, their female adult children? What are the factors that will go into deciding when those children should be screened?
I think, first of all, we need to make sure that they're not at risk of the family itself has a hereditary, because that's important to make sure, and that's what like 5 to 10%. So we take a very good family history and we send them. And you know what? Sometimes it's not even a family history. Like right now in Ontario, any woman who has triple negative breast cancer less than age 60, even if she doesn't have a family history, she can get genetic testing. In general, I tell people that their kids are, if you have breast cancer, your kids are more risk of having breast cancer. So, and especially for Black women, even, any Black woman in her 20s should be, or as young as that, should be aware of what we call breast awareness. So, and then they should advocate, although it says it's 40 years, but let's say they had the breast cancer when her mother had the breast cancer at the age of 40, then I think it's reasonable to discuss with the family doctor and have screening starting at the age of 30, and also to work on all the other risk factors, such as, making sure, weight and alcohol and all of those. So I kind of tend to individualize it, but it's also important to empower the family and make sure that they access services, they get more, and also these things are being updated every day. So they need to be always in touch with their providers and with their genetic counselors to know what's new and how they can decrease the risk in their daughters and also in their sons if they're, if they have the RCA mutations in general. Yeah.
Thank you. Our next question, I'm going to look to both Dianne and Francine, and it's just about recovery after mastectomy. And if you could just talk a little bit about that experience and what somebody should expect with regards to pain, for example, or just the recovery process.
So the recovery process after mastectomy, it's overwhelming because you go in and you have your breasts and then all of a sudden they're gone and you have drains and you have a bit of a recovery time. Usually you have nurses coming in as well and changing bandages. And, people say you can prepare for it by getting bras that will hold the drains and everything. And that helps. It does take maybe two weeks, but emotionally it's very, very difficult. It just feels like you've entered a different world and you need the support of people who've gone through it to say that they've gone through it and they have recovered and they're better. And you have a lot of questions. The Olive Branch of Hope, which I'm a part of, had a surgeon who did mastectomies, and they were able to answer a lot of questions. And so, get the questions answered, go through the things that you're afraid of and work through them. And also definitely, get counseling. And it does take a while to heal, but you do heal from it.
For myself, I had both a lumpectomy in the beginning and I had a double mastectomy recently. I actually found the double mastectomy much easier. The lumpectomy, because I was heavier breasted, my breast tore. You do have to go through the drains, but my recovery from my lumpectomy was a longer process, and because my scar, because of the wound tore, because of the heaviness of the breast, that delayed my healing. But the double mastectomy was probably one of the easiest procedures I've had throughout this treatment. My radiation was actually the hardest. Radiation was the hardest because they didn't really prepare me for the amount of pain that comes with the healing of the skin. So that was the hardest part for me.
And I just want to make a point that as a clinician, hearing these two women say, describe their experiences so differently, that's true, because people are people and everyone has different reactions to different things. And so just because you have a friend or a relative who experienced it in one way doesn't mean that you're going to experience it in the same way.
Thank you for that very important point. So with just 1 minute left, and this might be, I don't know if this can be covered in 1 minute, but hair relaxers. So I'm again looking at our clinicians. Can you talk a little bit about hair relaxers and what do we know about the risk of cancer for hair relaxers at this point?
There is actually, gosh, you guys got me. There was an article today in the New York Times that I bookmarked that I didn't finish reading, but I'm going to kind of be the bad guy and say that hair relaxers are dangerous. They are not well, I mean, only very recently have they started being studied. They contain a lot of chemicals that in the European Union are banned, compared to North America versus Canada. I say that having, relaxed my hair for a long time, from when I was a kid until, for a long time, I think a lot of us have, it's our hair. We've had these hair journeys, and I love being able to talk about this stuff with all of you guys. Hair relaxers are dangerous. They're associated with an increased risk of uterine cancers, fibroids. They are not safe. They're not well studied. I would strongly recommend against the use of hair relaxers. I'm kind of going off the cuff, but that's true.
We need to study them more, actually. Their effect.
Thank you. So I think with that concrete piece of advice and an important point that we need future research on, I think that we will wrap it up. I will ask if maybe folks on this panel can just try and answer some of the questions that are remaining. And thank you all so much for joining us.
Thank you.
Thank you.
Thank you to our panelists and especially our patient speakers, Laura, Dianne, and Francine, for your courage and for sharing your story with us. Your stories have been both powerful and inspirational. Thank you. We heard a lot from this panel, talk about advocacy, advocating for yourself, getting a second opinion, knowing your family history, sharing your stories with others, sharing your journey so that we can all learn from it, as well as the importance of research and how important research is for Black women, because it will definitely help to inform future treatment as well as policy as we move forward. So thank you to our amazing panelists for the wonderful and informative discussion that you've just shared with us. It's time we'll take a moment to take 5 minutes for an intermission, a quick little break. And during this time, we'll share some resources with you. And we'll also drop the resources in the chat for you to access later on. And we will return exactly 8:08. So we'll see you in a few minutes. Thank you.